afternoon, good evening po sa lahat. Saan man panig po kayong daigdig naroon. Welcome to our 139th episode, 139 episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who have just discovered us today, welcome po. Sana po marami po kayong matutunan. So you all know that cardiovascular diseases, they're the leading cause of death globally. Bawat taon po, estimated that the global number of deaths, about 18 million. And 4 out of 5 deaths are from heart attacks and strokes. Sa Pilipinas po, it accounts for 1/3 ng lahat po ng namamatay. And in the year 2020, estimated po na 62,000 ang mga namatay sa heart attack. So for today, we will be tackling innovations in cardiovascular medicine. Very exciting topic, and I hope lahat po kayo ay maraming matutunan. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of Philippines, Manila. Always a pleasure to be with all of you during our regular Friday, and always looking forward because I get to share hosting duties with our adjunct research faculty at the National Telehealth Center and internationally renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie, welcome back.
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat. It's great to be back, and I have COVID, Raymond.
But hopefully you're feeling better.
I'm feeling better. I had 2 days na I was kind of knocked out, but I'm okay. But it's not yet over. May COVID pa rin, so okay lang. Anyway, mahaba naman ang hair ko, Raymond, di ba?
That's true. Medyo lumilipad.
Okay, so binabati ko po kayong lahat. Saan man kayo naroon, good afternoon. Good morning, good evening to everyone, especially those of you who are on the Zoom with us. Those of you watching us live on Facebook, YouTube, TV UPs, YouTube, and also those who are watching on UP System Facebook page and the Stop COVID Deaths Facebook page. Maraming page to, Raymond, And all of those who are watching us on TV UP Signal, TV channel 101. Pasensya na po kayo. So we are also greeting all of you watching on the playback, and I'm sure you're going to love this playback. We have a great speaker today. Yung mga wala pa, tawagan nyo na yung mga kaibigan nyo, sabihin nyo nandito si John Anyo Nuevo, ang chair ng medicine. Talk about this in a bit. We are going to talk about cardiovascular disease. Marami pong nagkakaroon ng sakit sa puso, and napaka-importante po nung access to medicines and early interventions. Preventive measures are equally important, like managing your hypertension, taking your meds, reduction of salt intake, diet, physical activity, not smoking, not being exposed to secondhand smoke, and avoiding the harmful use of alcohol, and of course, managing stress. So ito po ay pag-uusapan natin. Our Stop COVID Deaths program is not just covering COVID, but we said it covers the continuing issues of COVID. Kasi may mga nagkakaroon pa ng COVID, katulad ko, other outbreaks, viruses, infections, and disasters. So as I said, tawagan nyo na ibang mga kaibigan nyo. The main presenter is Dr. John Anyo Nuevo, Chair of the PGH Department of Medicine. You do not want to miss this lecture. And for those of you who can't stay and watch the whole thing, of course, you can watch it on the playback. He will talk to us about innovative procedures in the cardiovascular space. Our reactor is Dr. Dennis Bautista, who is practicing radiologist from Hospital ng Muntinlupa, but he is not going to be a reactor as a doctor, but as a patient who has gone through 2 cardiac events. So pag-uusapan natin yan. And of course, synthesis and closing, none other than Dr. Stella Marie Legaspi Jose, who is the head of the PGH Office of Expanded Education and Training. And as you know, as we all know, you all want to hear about the latest news in medicine and public health. And it's for this reason that we bring you the news update.
Okay, everyone, for our very first news update, yung old school printer po, nakakatulong daw po sa mga scientists, no, na may identify yung bacteria in the blood within seconds. So may mga scientists po sa Stanford University, they have repurposed a standard inkjet printer, yung, yung mga ginagamit po natin sa pagprint ng mga dokumento to print over 1,000 tiny spots of blood per second, which were then scanned using a Raman spectroscopy and also machine learning to detect and identify bacteria signatures. According to them, what they're finding is that from the Raman scattering, they can use to identify, even without incubating yung mga antibiotics po, no? They can identify which drug the bacteria would respond to. And very, very exciting daw po ito. Ito po ay ayon sa study author na si Jennifer Dion. So, very, ano lang po, no? Something innovative, something that we haven't really thought about. Pwede palang gamitin ang printer para mag-identify ng bacteria sa dugo. And good thing that this is pinag-aaralan po ito at sana po mas antabayanan pa po natin ang mga advancements in this regard. Dr. Susie, what's your news?
Yeah. Okay. So it seems like there will be a delay in the delivery of donated bivalent vaccines. We were talking about this last time, Raymond. No? There will be delays delivery from the COVAX facility. They were expected to come this month. No. Apparently, there are certain conditions like immunity from liability and indemnification clauses which are required by manufacturers and international agreements, which must be dealt with as the state of calamity was not extended. So I think this means a little bit more due diligence, paperwork, and all of that. And so there is expected to be more than 1 million doses of bivalent jabs in the 3rd or 4th week of this month. And that's our news for today. Next week, we'll be back with more news on the news update. Okay, and we are back. We've got a great topic, something that affects all, what should I say, all families. I'm sure all of you who have somebody in the family who's had heart disease. And so we're going to listen a little bit to what persons on the street are saying. So Raymond's going to introduce this section. Raymond, go ahead.
Thank you so much, Dr. Susie. And for all those who are joining us for the very first time, we set our discussion into context po, no, by watching this very short video produced by the TVUP team. We asked the common folks on the street, meron po ba kayong kilala na may sakit sa puso? Ano ng mga procedures ang dinaanan po niya or nila? At paano kaya makakaiwas sa sakit sa puso? Please watch this.
May kilala po akong may sakit sa puso. 25 years old po siya.
Yung father ko, taga Caloocan ko. Yung father is a city council before in Caloocan.
Yung tatay ko, namatay siya sa atake sa puso.
Actually po, may friend po akong na-diagnose recently na may sakit daw po sa puso.
Nakuha niya yung sakit niya sa puso hereditarily. Meron siyang congenital heart disease, ventricular septal defect po yung tawag doon sa kanya.
Nakaranas siya ng quadruple bypass surgery kung saan inoperahan yung puso niya na parang baboy, biniyak, kumuha na ugat sa kanyang hita.
Siguro, na-angioplasty o yung kung ano naman yung tanggal yung bara sa ugat, mga ganon. Kasi matagal siyang nandun sa ospital eh.
Hindi ko pa sure kung may pinagdaanan na po ba siyang procedures, pero ang alam ko po, nagtitake po siya ng maintenance test para hindi na raw po lumala.
Pag-uwi niya ng bahay, akala niya nagkakaroon siya ng heartburn or acidic attack. Hindi namin alam at hindi rin niya alam na ina-atake na siya sa puso. So, uminom siya ng aspirin, uminom siya ng antacid, tapos yung time na yon, ang sabi niya sa mom ko, parang medyo bumibigat yung sakit ng dibdib niya.
Wala pa po siyang surgeries na nagagawa sa kanya, pero meron pong mga test na nire-run para ma-check yung update sa kalagayan ng puso niya, which are ECG, 2D echo, CBC, tsaka mga blood tests po.
Nasa lahi kasi namin yung may heart disease eh. 3 times siyang pinamaan ng atake. Yung pangatlo yung fatal.
Ang naging advice ng cardiologist namin ay 1, angioplasty or 2, open bypass surgery. So yung pinaka-easiest way at hindi ganun kagastos na proseso is yung angioplasty. Ang problema sa dad ko noon, 4 na ugat ang barado. Ibig sabihin, hindi na siya kaya ng powers ng angioplasty. So kailangan talaga ng open bypass surgery which costs millions.
Para po maiwasan yung sakit sa puso, dapat pong umiwas sa mga hindi masustansya na pagkain, lalo na po yung mga cholesterol. Dapat din po mag-exercise regularly at iwasan po yung paninigarilyo.
At awa ng Diyos ngayon, 2023, naka-recover na siya. At talagang sinasabi nga nila, pag nagkaroon ka ng open bypass surgery, parang bago puso mo. But still, I suggest sa ating mga bilang advocate ng pagmamahal sa ating sarili, sa ating puso, alagaan natin yung sarili natin, alagaan natin yung mga maging conscious tayo sa mga pagkain na kinakain natin. Kasi later on, yung mga ginagawa din lifestyle ng bata tayo, it will affect us in the future. So kung mahal natin sarili natin, mahalin natin kung anong ginagawa natin, mahalin natin yung lifestyle natin.
Thank you very much, TVUP. It's always great to hear the view of persons on the street. And people seem to know, Raymond, people seem to know a lot about cardiovascular disease and the different procedures. Pero meron tayong may mga dalubhasa tayo ngayon who are going to tell us even more about management of cardiovascular disease and also prevention. Over to you, Raymond.
Thank you, Dr. Susie. I see there a little bit of housekeeping po. May mga nagsasabi na hindi pa po sila nakatanggap as far back as webinar 134, 135. Although may mga chinek na po, we will still again check our records. To our knowledge po, na-submit na po natin yung up to webinar 137 na nasa-send out. But we'll keep rechecking our records for this one. Please note that certificates of attendance will be given to those who have watched at least 50% of the webinar duration. For our webinar today, we'll be having our standard panel discussion format. After our speakers have presented, we will hear from our reactor and then followed by a Q&A session. So right now, we'll move ahead with our cute introduction for our fun quiz segment.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Okay, thank you. Thank you so much, TVUP. May we have on the screen po yung Slido and fun quiz poll dito po sa Zoom. Thank you so much. Can we have it? There we go. Okay. Where we are now at webinar 139. We have 2 questions for today coming in from our main speaker, who's the chair of the Department of Medicine of Philippine General Hospital. First question po, ano ang mga palatandaan na ang isang tao ay may posibilidad na may heart attack or nagkaka-heart attack po siya? Letter A, pananakit ng dibdib. Letter B, hirap sa paghinga. Letter C, pamamanhid ng kaliwang bahagi ng katawan. Or letter D, lahat ng nabanggit. Okay, before we go into our second question po, we'd like to greet those who are coming in, watching from Vegan City in Ilocos, from Iloilo City, the Central Philippine University, from Baybay Family Care and Maternity Clinic in Baybay City, Leyte, from Ozamis City in Misamis Occidental, specifically from the MHARS or Mars Medical Center, from the University of Philippines Cebu, from St. Louis University, St. Louis Review Center in Legazpi City in Bicol, and Tombok Salayog Hospital in Tacorong City in Socsargen. Those who are watching from ARMMC, thank you so much, Prof. From UP Las Baños, from RPHS Annex 1 in Antipolo, the New Sinai School and Colleges. Maraming salamat po for your constant po at patuloy na papanood from Pampanga. May mga nandito rin po, mga nanonood from Pampanga, from Iloilo City, from University of Rizal System, Morong Rizal. Thank you so much. From Ward 1 ng Philippine General Hospital, maraming salamat sa inyong suporta. Rizal Medical Center, Las Piñas General Hospital, University of Rizal System Health Services from Bataan, from UP-PGH Medicine Ward 1, okay. We're seeing the support being provided to the chair. Thank you so much. From Amante Hospital in San Pedro, Laguna. So for our question number 2 reads, what are the therapeutic options for a patient experiencing an acute heart attack? Is it A, thrombolytic therapy? Is it B, angioplasty and intracoronary stenting? Is it C, medical management? Or is it D, all of the above? We'd like to greet those who are joining us. Yan, nakita na po natin from University Al in Kingdom of Saudi Arabia, from Chonin Hospital in Taipei City in Taiwan, Lunichi Ali University of Blida 2, Algeria, from Island Hospital in Penang, Malaysia, from Abilin, if I'm reading this correct, Abilin, Texas, from Canadian Medical Center in Dammam, Saudi Arabia, and the Kiangwu Hospital in Macau. Meron din po nag-shout out, pahabol po from the Health Information Management Division, Department of HRRS in the Philippine General Hospital. So lahat po itong mga kasagutan po natin dito, tatanungin po natin yan sa ating main speaker, and we hope we'll be able to get the correct answers from our main speaker po for today. Okay? So we'll proceed now with our topic at hand, and for our webinar for today, we always aim to bring you the very best po, no? Our main presenter, I'm sure everyone is excited. He is the chair of the Department of Medicine, Department of Internal Medicine po, no, ng Philippine General Hospital. He is one of the best practicing cardiologists po sa Pilipinas, and really it's an honor and our pleasure to have him for the very first time in the webinar series. Please give a warm virtual welcome to Dr. John Anunuevo. Dr. John?
Hello?
Yes, sir. Yes, sir. We can hear you. Can you? Yan. There we go. Okay.
Okay. So, good afternoon, good morning, and good evening. First of all, to Raymond and Susie, thank you for this opportunity to be able to join you this afternoon here in Manila. And it's a pleasure to be able to share information to all our listeners, no? May disclosure lang ako because this is innovations in cardiovascular medicine. So we'll be talking about some highly technical innovations, no? I hope I will be able to relay the information, and I will do my very best to make it a little bit simple so that all our attendees will be able to appreciate the information that I will be sharing with them. So, can we start already?
Go ahead, Dr. John. Please share your screen.
Okay. Yep. Thank you. There. Wait. Hold on now.
Sige, sir. Go ahead. No problem. No problem.
Bigyan yung ating kanina. Ito lang. Yung huli natin ginawa.
Sige, sir. No
Okay.
problem. There we
Sorry,
go.
sir.
Okay, there we
Just
go.
had,
Go ahead,
some minor
Dr. John.
problems there. Okay, so as you can see, ang title ng ating lecture is Kamusta ang Puso Mo? Okay ba to? And we will talk about innovations in cardiovascular medicine. These are my disclosures. And let me start with the picture of what is the present division of cardiovascular medicine in UPPGH. This division has existed for at least 5 decades already, committed to delivering excellent care to our PGH patients, training future cardiologists who have been distributed across the provinces of our country, and of course, done multiple research projects whose output have helped in the delivery of medical care among our patients. This is the Division of Cardiovascular Medicine. It has really expanded by leaps and bounds, and you can see now, it used to be the section of cardiology. Now it's a division, and it has 6 different sections already. The section of electrophysiology, echocardiography, cardiac catheterization and intervention, vascular cardiology, and then the newer ones are your heart failure and cardiomyopathies, and of course, nuclear cardiac rehab and critical care cardiology soon to come. This is what we've been doing, as I have mentioned, delivery of service to our patients, a lot of diagnostic tests, and of course, interventions and therapeutic options that are given to our heart patients, and a very well expanded and productive research unit. So let me start with our cath lab, which was inaugurated 25 years ago in 1998. This actually was the 5th cardiac cath lab that opened in Manila in 1998. No? It was the first digital biplane cath lab in the Philippines at that time, and at present, we actually have 3 cath labs. Imagine PGH in 1998 had 1, and then eventually through the support of the administration, we have now 3 cath labs in this institution. And the cath lab is actually designed to offer services for our patients with coronary artery disease. And one of the most commonly used diagnostic tests is what we call coronary angiography. I'm sure some of our attendees might have had this test already, or some of their relatives, but it's basically considered to be the gold standard to appropriately diagnose, manage patients with blockages in their coronaries or patients with coronary artery disease. You have to realize though, and this is basically that will serve as a background for my talk on innovations, even though it is considered to be a gold standard, it has its own inherent limitation. Remember, it's just a 2-dimensional picture of a very complex 3-dimensional vascular structure. I am quite proud to say that Philippine General Hospital has a very effective STEMI pathway. Those patients who have an acute ST segment elevation myocardial infarction goes through a very systematic, effective pathway such that we are targeting, I know this is quite difficult to do, what we call a door to balloon time of 120 minutes, which means that once the patient once he's admitted at the emergency room, we're given that time period to be able to bring him to the cath lab and do the procedure, what we call primary percutaneous intervention. You can see here the period that is very important so that we can save as much myocardium as possible in the setting of an acute myocardial infarction, 120 minutes to have a PCI or a percutaneous coronary intervention. Just to give you a picture of the number of cases that we have done in terms of primary PCI, and considering the limitations and struggles we had during the COVID period from 2020 up to 2022, we have actually offered an average of 120 PCI cases for the whole year, which is a good number. And at present, these numbers are going up actually. So just to appreciate exactly what I mean by doing coronary angiography and doing a primary intervention. If you have a patient who is in the emergency room having severe chest pains, diagnosis is acute myocardial infarction, that patient is wheeled in at the to the cath lab, and we do a primary percutaneous intervention. So the arrows here points to the artery, which is the left anterior descending artery, which is a very big vessel. We call that the money vessel. And you can see that there is actually a trace only of the artery. You barely see it because it is totally occluded. The artery that caused the heart attack is the left anterior descending artery, and you don't see it here. And when we do primary intervention, when we do what we call angioplasty and stenting, you can see the wire is already inside the left anterior descending artery. Now you can see how beautifully the artery has been recanalized. There is now adequate blood flow. This is the left anterior descending artery, very visible already after doing a PCI, after placement of a stent in the left anterior descending artery. And if you improve the blood flow in this artery, you will save a lot of myocardium and the patient will definitely get better. One of our video later on is a patient who had actually an acute myocardial infarction. As I have said earlier, angiography has its limitation. It cannot fully characterize the clinical significance of stenosis. Just to point out here, this same lesion would have a 75% and a 25% dependent on the view that you will be getting. Second, it cannot identify intraluminal details, which talk about calcium. We're talking about the atheroma burden. This is not seen in the conventional 2D coronary angiography. So these are some of the innovations that have been discovered for us to be able to visualize better the lumen of our coronaries. And one of the more commonly used new innovation is the IVUS, or intravascular ultrasound, and the OCT, which is your optimal coherence tomography. These two other entities, the angioscopy and the near-infrared spectroscopy, these are basically used in the laboratories and not at present used clinically. What are the advantages of having these new innovations in terms of coronary imaging? You're talking about improvement of diagnostic accuracy. You are able to optimize the results of intervention. Unfortunately, because of the increased cost, the increased manpower, resources, and of course, the expertise that is needed, the utilization remains quite low worldwide. But I am proud to say that PGH Cath Lab has an IVUS and an OCT machine that we are able to use for most of our patients. So this is IVUS, as I have mentioned to you. It is an image that is formed by ultrasound waves that bounce off tissue or vessel walls and layers of the artery and is returned to the transducer. The greater the acoustic impedance or density of the tissue or vessel wall, the more waves are reflected back and the brighter it appears. So IVUS, the first catheter vascular imaging, was actually developed in 1971, and it has been refined throughout the years. This is just to show you the difference between a two-dimensional coronary angiography where you don't see the lumen compared to having an IVUS done. This is a normal coronary anatomy by IVUS. You can see the three layers of your vessel wall, from an intima to a media and an adventitia. So you were able to see and appreciate the vessel wall of your arteries doing the IVUS. Again, a picture of a normal coronary anatomy by IVUS. But this is now an abnormal IVUS. You can see that it's not as clean and as smooth as I have shown you in a normal vessel. You can see the extent of the cholesterol plaques. This is the atheroma burden, the atheroma area. And from 100% luminal diameter, now you have this degree of stenosis. And you can see it better, the illustration here, where based on the IVUS, you will get a better estimate of the stenosis of your coronaries and also the atheroma or the plaque burden in that specific disease coronary artery. Not only are you able to document the plaque burden and measure the stenosis, but you're able to characterize the plaques. This is a patient with concentric fibrofatty plaque. And the next one, I will show you a patient with very calcified plaques. And these findings, this characterization of these plaques, this will guide you actually to what kind of intervention can be best provided for that particular patient. There are some interventions that you might need to do, especially in a calcified plaque, before putting a stent. So this helps us plan the interventions for our patient. The other very nice imaging is your optimal coherence tomography. It's an optical imaging modality that uses near infrared light to create high resolution images of your tissue microstructure. So the first one I showed you was the IVUS, but this is the OCT. Look how beautiful the pictures are. Why? Because the resolution is 10 times better than the IVUS. So there are some cases where OCT might further help you decide what kind of intervention you would need. These are, again, some pictures of a patient who had optimal coherence tomography, looking at a patient with a fibrous type of plaque, a lipid-rich plaque, and a very calcified plaque. There are some characteristics that are peculiar to each of these three types of plaque. Now, we've looked at the anatomic images. The IVUS and the optimal coherence tomography pictures are anatomic, but there's also what we call functional or physiological measurements that will tell us whether a patient has significant coronary artery disease or not. Remember, as I have mentioned earlier, when you do a conventional coronary angiography, that's only two-dimensional. And there are some pictures where it actually appears stenotic or severely narrowed when in fact it's not, and vice versa. The use of functional or physiological measurements such as the FFR or fractional flow reserve is able to guide us whether we would need to intervene or not. There are some particular cases where angiographically it will appear significant, but when you do physiologic studies, no intervention is necessary. So FFR is considered to be the gold standard for the assessment of the physiological severity of your CAD, which means we really need to know the anatomic and the functional severity of our coronary artery lesions. And FFR, during diagnostic angiography, we do measurements of our CFR, or our coronary flow reserve. It is derived from measurements in the aorta, or proximal to the lesion, and distal to the localized coronary artery stenosis. I will show you the picture of what we do when we do FFR, assuming that this one is the lesion in the left anterior descending artery. You actually very simply get the pressure distal to the narrowing. That will serve as your numerator, and then the pressure proximal to the proximal to the lesion rather, that will serve as your denominator, and that ratio will give you some numbers. And the magic number to remember is, if you have a fractional flow reserve of less than 0.80, that means that lesion is very critical, very significant, and you might need to do intervention. If your FFR is more than 0.80, then intervention is not necessary. So let's go now to looking at the value of non-invasive studies. This is the use of 3D and 4D echocardiogram. I am pretty sure that most of our attendees, by this time, when you're about 50 or 60 years old already, you probably had a 2D echo already. It is a very useful cardiac imaging study. It's cost-effective, and it can identify a lot of pathology. But I'd like to share you two advancements, again, innovations that are available in PGH. This is what we call the global longitudinal strain by speckle tracing, or what we call shortly as GLS. No? So medyo pasay na yung doing lang 2D echo. Now we're able to do GLS in addition to 2D echo and 3D echocardiogram images. What is GLS, or global longitudinal straining? It is a non-invasive assessment of the global and regional myocardial function. It is actually a myocardial deformation analysis that reflects the function of subendocardial longitudinally oriented fibers. So it looks at the shortening and the lengthening of our myocardial fibers. And they identify, based on studies, that these fibers are the ones that are most prone to ischemic damage and wall stress. Remember the magic numbers again. It is acceptable that based on the inter-vendor variability, based on what machine that you are using, the usual GLS is at least a negative 18%. Any value below negative 18% is abnormal. You would want a value above negative 18%. These are some of the clinical applications of GLS. This is some pictures that I am sharing with you. This is a normal picture. It's colored red. All the segments are contracting very well. The GLS look good. But when you start looking at a patient where there is what we call apical sparing, this is the apex of the heart, the one that is colored red. But around it, the other areas, it is abnormally colored, not the red one. The numbers look low. This is a patient with what we call apical sparing, very suggestive of cardiac amyloidosis. So there's a pattern recognition when you see apical sparing, that is cardiac amyloidosis. The second value is subclinical dysfunction. You might have patients, especially those who will undergo chemotherapy, whose ejection fraction by 2D echo is good. But if the GLS is below 18%, below negative 18%, the chances that this patient will develop a chemotherapy-induced cardiomyopathy is very high. We also use this GLS in monitoring patients in terms of their adverse effects related to the use of chemotherapy. And the last one is regional variation. You can see here in this area where it's colored blue, the GLS strain is abnormal compared to the other parts of the heart. This is a patient who actually developed a myocardial infarction in that area. So very useful. These are some pictures of our patient who had amyloidosis. This is a major innovation in cardiac ultrasound. As I have mentioned, the 3D echo is now used in some of the cases that we do in PGH. It is a major innovation, especially in the assessment of your chamber volumes and mass, the assessment of your left ventricular wall motion. And I think the major use of this 3D echo is in patients with valvular obstruction, specifically those patients who have damage to their mitral and aortic valves, our rheumatic patients, patients with degenerative valvular diseases. And I will just show you an example of the patient. This is a patient with a normal mitral valve, normal aortic, and normal tricuspid valve. This is the mitral valve. This is the aortic valve. This is the pulmonic, and this is the tricuspid valve. Now, I will show you now a patient who has rheumatic mitral stenosis. You can see the fish mouth appearance of this mitral valve. It is severely stenotic. The anterior leaflet is opening, but the posterior leaflet is not opening. So this is a patient with rheumatic mitral stenosis. Look how beautiful the pictures are when you do a 3D echo compared to just doing a 2D echo. You will see more structures. You will see better definition of your valves. And this, again, will help you in decision-making in terms of what surgical intervention can be offered to these patients with rheumatic heart diseases. This is a patient with mitral stenosis. Another one that your 3D echo can help us is your assessment of congenital heart defects. This is a patient with atrial septal defect, and you can practically see the hole in his interatrial septum. No, let's wait for it again. Let's play this again. There's the hole. You can see it. No, how big the hole in the interatrial septal. Very diagnostic of a patient with an atrial septal defect. You will never get to see these beautiful pictures in a simple 2D echo, and that's why 3D echo now is very important. And you can ask for this in our institution. We have 3D echo and 4D echo. I've mentioned about its utility in rheumatic or valvular diseases in patients with congenital. And then you can also get a better picture or a better assessment of your ejection fraction. This is your ejection fraction of your patients with heart diseases. So now let's go now to the another innovation that we have. Our electrophysiologic studies are now available in PGH. We've been doing this for 1 year already. As of today, I was told that we are now looking at the 40th patient who had ablation therapy. So what is ablation therapy? Special cells in your heart create signals that travel along pathways, no? What we call the pacemaker of the heart. And these signals make the heart's upper and lower chambers beat in proper sequence. But when you have abnormal cells that can create disorganized electrical signals, that can cause arrhythmia. And when your arrhythmia is very rapid, it can cause symptoms. Sometimes you may feel very short of breath and weak, and sometimes patients actually go into sudden cardiac death. And that's the reason why catheter ablation is needed for some of these patients not responsive to medical therapy. Radiofrequency ablation, or RFA, has become the standard of care for the management of various arrhythmias. In fact, sometimes it becomes the first line of therapy for many tachyarrhythmias. What we do in catheter ablation is we use radiofrequency energy. It's similar to what we have in microwave that will destroy a special area or a small area of the heart that is the one responsible for causing rapid and irregular heartbeat. These are just some of the type of arrhythmias that can be treated, from AV nodal reentrant tachycardia, even AFib now. Ablation is already offered to AFib and some forms of ventricular tachycardia. the success rate is quite good, over 90% in patients with supraventricular tachycardia and a little bit lower in those patients with ventricular tachycardia, especially after a heart attack. One special innovation that we have is the 3D mapping that is available in our cath lab. This is used to identify or to demarcate scar regions so that they can be isolated, and you allow catheter positioning during the ablation without the use of fluoroscopy so that you can reduce procedure time. This is one innovations that is available in our cath lab. So I have shown you three major innovations. The use of IVUS and OCT and FFR in those patients who have significant coronary artery disease, the ablation therapy on our first year already, and of course, the use of the last one that I shared with you, the 3D mapping, which is available, and of course, the 3D echo in our patients. So I will end my talk with the importance. I've shared you technical innovations, napaka highfalutin words, innovations that are just coming out. But what I'd like to share with you in the last few minutes of my talk is the importance pa rin of taking good care of yourself, having a good nutrition and exercise para maiwasan natin ang sakit sa puso. No? We don't want to end up needing those interventions that I have shared with you. Very important po itong last few slides. Weekly exercise, 150 minutes per week of moderate exercise will improve your heart health. Very important. And the recommendation, you can see here, warm up, increase your pace, alternate intensity. You need to look at your heart rate. You have to achieve a certain heart rate to be effective, and the importance of cool down. A 7-minute workout daily, 7 days, you will lose between 1 to 2 inches. I'm sure most of us would want that.
This is a 7-minute workout that you follow this for 7 days to lose between.
And remember these numbers, 52100. 5 servings of fruits and vegetables per day, 2 grams of added salt per day, 2 hours of maximum screen time, 1 hour exercise per day, 0 smoking, and 0 sugared drinks. 52100. So at the end, this was our last Heart Week month. We presented the value of what I have shared with you, the 52100, to our PGH patients. So with that, I'd like to end my talk, and this is our PGH Cath Lab team. And as always, we are here to offer our services to our countrymen. Maraming salamat po sa pakikinig. Thank you very much.
Thank you so much, Dr. John. Okay, here we go.
Sumakit lang po bigla yung dibdib ko. Eh sabi heart attack daw eh. Andok astig pa, hindi ko
Okay.
lagyan ko ng stent.
Ilan daw?
Medyo gumanda na pong pakiramdam ko at lumag na po yung pakiramdam ko sa dibdib ko.
Okay.
Nawala yung kirot at saka yung
Okay.
bigat ng dibdib
Sige
ko.
po.
Ako, nagtrabaho pa ako bilang isang driver ng company. Wala po ako ibang pagkakitaan
Okay.
para ipapakaiwan ko sa pamilya ko. Kaya ako'y pumilit na bumalik. Pero siguro, dandahan lang po siguro. Hindi na. Malaki po talaga may tulong. Malaki at malaki ang may tulong talaga sa
Okay.
ako.
Sige.
Ko bang malaman kung ano yung naging diagnosis mo sa puso? Nagpa-medical po kasi ako. May inapayan po kasi ako. Tapos nakita po sa ECG ko, may WKW. Pattern daw po ako. Tapos, tinahanap po ako ng doktor sa cardio. Sabay, yun na po, in-explain na may, ano daw po, may kuryente na dapat na sunugin. Tapos, ni-repair po ako dito sa PGH.
For procedure, no? For yung tinatawag nating RFA or radio frequency ablation. Parang wala ka naramdaman at that time, pero bakit kinailangan daw na gawin pa ito? Ano daw yung naging implikasyon sa kabuhayan mo nung meron kang WPW? Naipaliwanag ba sa inyo?
Delikado daw po. Pwede po anytime bigla akong atakihin. Lalo na po kung nasa barko ako, wala namang hospital na malapit doon. Pwede akong atakihin. Kaya mas maganda daw po na kailangan na operahan po yun.
Oo, tama. No? Lalo nga dun sa nature ng trabaho mo, anytime pwedeng mangyari. At hindi lang yung buhay mo, yung nasa panganib, pero pati yung mga tinutulungan mo at pinagsisilbihan mo doon sa barko, no? Lalo kung may mangyari sa'yo. So yung RFA or ablation ay nagawa na dito sa PGH, no? Kailan siya ginawa?
Itong ano po, December 14 po ako na operahan.
Kamusta yung naging procedures?
Okay naman po, mabilis lang po. Saka magagaling po talaga yung doktor dito.
Okay. Ngayon naman po ay makakabalik na kayo sa work at pinayagan na kayo or already processing na makabalik na?
Opo, clear na po ako. Saka mas okay na po ako. Nakakampante na ako na hindi na ako atakihin kasi clear na po eh.
Salamat po. Salamat sa naging kwento mo sa amin. Sana nga gaya mo, marami pa kami ibang pasyenteng matulungan. No, sa tulong din ng mga ibang ahensya na magbibigay sa atin ng funding at support para sa radio frequency.
Thank you.
Thank you. Thank you.
Na-found out po noong 2004 na meron akong rheumatic heart disease. Tapos itong 2021, nag-moderate mitral stenosis. Kasi nag-severe na siya itong February 2023. So, sabi ng cardiologist ko, dapat surgery na yung dapat na gamot doon, hindi na siya. March 16, 2023.
Yung mitral valve replacement po, ano? Sige po. So,
nirehab ako ni Doc Lukban. Nakalakad na po ako ng mabilis na hindi ko nagagawa noon at saka hindi po ako hiningal. Administrative officer
okay.
po. 2 months lang po yung leave ko.
Okay.
Looking forward po na madagdagan pa yung year life expectancy.
Wow, thank you so much. Thank you very, very much. John. I'm just blown away by John's presentation. Galing-galing niyo mag-explain. Tsaka isa po yan sa pinakamahusay na cardiologist. Ayoko sabihin pinakamahusay, magagalit yung iba. Pero ang galing ng presentation. Really very, very good. I hope most of you will go back. Very visual, no? Papakita talaga niya siya, tsaka yung appreciation niya ng mga structures ng puso. Napakahusay talaga. Thank you so much, John, and thank you to your team at the cardiology department in PGH for putting together the video on the patients. Also very important, no, na sabi ko nga, Raymond, no, parang talaga ang ano nila, makabalik sila sa trabaho, no? So we're really looking at an
Very
age group.
important, yeah.
Pwede pang maghanap buhay. So, ang laking tulong talaga nitong nagagawa sa PGH. Diyan, ang galing-galing mo. Ano ba yan? O sige, let's go to our next speaker. We have a reactor. Okay, as our reactor, we have a doctor who is a radiologist. He's practicing at Hospital ng Muntinlupa. And kaklase mo ba? Hindi kayo magkaklase ni John, no? But he will talk about his experience as a patient who has had 2 cardiac events. One in 2017 and one later on nung nagka-COVID siya. So let me welcome Dr. Dennis Bautista. Dennis, welcome to the webinar. Take it away.
Okay. Good morning. Good afternoon na pala, sorry. Oh, can you see me now?
Yeah, nice and clear.
Thank you for that warm welcome, Dr. Susie and Dr. Raymond, and thank you to Stella Jose who dragged me into this at the last minute. And to Dr. John, I liked your lecture, especially the images, since our specialty likes images. But I like, it's very wonderful to see the latest. And I'm here not because I'm a radiologist, but because my experience as a patient. Back in 2017, in December, I went to work in a clinic in Mega Mall. But in the afternoon, just while sitting, because that's all I do is sit and look at images, I started feeling this substernal burning sensation. It wouldn't call it pain, just the burning feeling there, but it was a persistent thing. It stayed there, and I tried a sip of water sometimes that relieves those similar symptoms, pero hindi gumana. So habang tumatagal, I was thinking maybe this is something more, a cardiac. Then I remembered about you have to take aspirin. Something like that happened. So I walked over to our pharmacy in the clinic and I got some aspirin. I went back to sit down and ganun pa rin. And I wasn't doing any work. I didn't feel like moving actually. Although walang pain, just that burning sensation. And if the question is on a scale of 10, kung ilan yun, so it's around 3 or 4 at the time, like that. And so I was trying to consider, no, cardiac event na ito. So it takes time to accept that fact if you're a patient, no? Oh, what can I do? Can I drive myself to the ER? Yung mga tanong yun. So I started praying. So, what can I do? And then my technician, my rad technician, came to me and said, "Doc, are you feeling okay?" Sabi niya, pwedeng hindi na tapusin yan yung trabaho niyo. You can rest na kung kailangan. So I said, okay. Pero yun lang sinabi ko. But what my technician did is she went to our clinic operations manager, Dr. Melanie Shapnoon. And later on, well, she was beside me and she was asking, "Doc Dennis, kumusta ka na?" So I told her, baka chest pain. Sabi niya, sige, i-ECG na kita, no? Since she's an internist also. So okay. It's so nice to be having this event in a clinic when you have all these diagnostic tools available to help you. So we went to another room and she did an ECG and she told me, after doing it, kailangan kang i-admit. Okay, so there's something serious happening. Kataon naman, the director, medical director of the clinic, Dr. King Enriquez, he was on his way home, pero the elevator was near our department to go down. Tinawag siya, "Uy, King, si Dennis, nakaka-MI." And then he came immediately and said, okay. He asked me, "Do you want to be brought somewhere in particular, or do you have a doctor?" So I couldn't answer those questions right away. I said, "Anywhere." And so he volunteered, "Oh, so he was cardinal, and I know someone." Sabi niya. Sabi ko, okay. anyone in that state, you just accept what's possible and what is available, you know. But actually, these are already part of the process of my prayers being answered, of having my text take care of me, Dr. Melanie there to do the ECG, and Dr. Enriquez, who just happened to be passing by on the way home saying, oh, I have a doctor I know. And so he volunteered to take me to the hospital. No? We were from Mega Clinic, we went to Cardinal Santos, and it's a short distance, but at that hour, say around 6, it's traffic. Pero he drove like an ambulance driver. Dr. King knew the importance of being quick, because he had just attended an ALS, advanced life support workshop. So he knew everything that needs to be done. And so they took me, and nice enough, one of our rad techs who was off duty now and a nurse accompanied us to help us out. And that was a nice gesture on their part. It's nice to have people caring for you when you can't care for yourself. And I was there, I just wanted to be a patient and be cared for now. So before we left the clinic, actually, Dr. King called his friend. His friend happened to be Dr. Timothy D. I didn't know him at the time, but he's an excellent interventional cardiologist pala. And so we were on the way to Cardinal. Dr. D had already diverted from going home from his clinic in Manila, Tondo, and went straight to the hospital. So when we got to the hospital, everyone there sort of knew that I was arriving. And then, of course, we have the residents asking you questions like this. And yung isang tanong na alala ko, ano ba yung naramdaman? So I said, parang chest pain, ano. Then he said, para bang meron nakadagan, para may block na, ano. Naalala ko, these are the questions we used to ask our patients when we were interns. But I couldn't say yes dahil hindi yun yung nararamdaman ko. It was just a burning sensation. Parang I didn't know the answer. And I thought, isn't this a little moot since an ECG was already done? And they already know there. But anyhow, I knew they were in training. They have to ask these questions. So I tried my best to do it. And then I was wheeled into the cath lab. Our time between the entry to the ER to the cath lab was just under 30 minutes, which apparently is quite fast. And it's well within the period that's standard, which is like 90 or 120 minutes. So he was there. And by the time I got there, Dr. D was already there. And actually, I heard later na naunahan pa niya yung team niya. Tuloy, napagalitan sila. But I guess the team wasn't expecting me to arrive that quickly, nor Dr. Tim. But he got there, but he was quite an amiable person. No? And Dr. King introduced me as the radiologist to the clinic and said, oh, then maybe you can critique my technique. I had no plans of critiquing anything. I said, no, I'm here as a patient. Yeah. Then he asked, what's the pain level? I think 4 to 5 right now. So he said, okay, no need for morphine. Sa loob-loob ko, sayang pagkakataon ko sana makaranas ng morphine. Pero no, it wasn't painful enough to do that. But that was only me, So during the procedure, the question would arise, do I want to see the images being done? Sabi ko, no, I don't. Kasi naintindihan ko yung itsura ng mga images. It might add to my stress if I find out, oh, that's blocked, everything's blocked and everything. So no, I would rather not do that. And there's a sheet over you naman when they're doing the angiogram first, But we don't know if it's going to be angioplasty lang or do the operation be required. And that was my big concern. Sana an operation would not be required and everything. So it's doing that. But as the procedure was going on, I hear the word stent. Just calling for a stent. Nabuhay yung loob ko ng konti dahil a stent, I think, so a stent can be enough. So that's a good thing. Yeah. So the stent was placed, and all of this was done. Siguro I didn't have a clock, but my feeling was it's like within less than half an hour, it was finished already. And oh yeah, well, during this, so I hear the word stent. Then I was thinking, because I'm familiar with the procedure, no, lalagyan ng catheter, so then the tube yun is going to the, threaded into the coronaries. Naisip ko, hindi ba kapag nandun yung catheter, nandun sa may bara ng coronary, hindi ba the catheter itself can block it for a while? Eh di mawawalan ng blood supply yun. I was thinking these things theoretically, within a minute after that, my pain level rose to 8 to 9. Sabi ko, ay naku, nangyari na nga. So fortunately, I knew that would be temporary lang kasi during the time of the stent placement there, or just before the angioplasty, to dilate it a bit, mabablocking blood supply for a while. I know that's temporary. Pero from 4 to 5 to 8 to 9, but that was probably less than a minute. Then the stent was placed and the pains subsided na. The pain didn't subside quickly, no? It was over the course of the later in the evening, right after, from 4 to 5, initially 3 to 4, in the evening 2 to 3, and then by the next morning 0 to 1, almost none the next morning. So stent is a wonderful invention. Actually, it's quite a miraculous thing to be able to open up the blocked artery and then give it supply again, no? Short of an operation. So that was a wonderful thing. Now, as a patient, what do you do? Kasi things are unknown, and what's going to happen? Everything's so unknown. So fortunately, we have faith. And yung ginagawa ko in those times I was just cycling Our Father, Hail Mary, Glory Be. I just kept repeating those to keep my mind, help keep my mind off it. And so then, but after a while, parang paulit-ulit, I thought of something which I learned na God hears the prayers of those in pain, especially if you ask them to help others. So I remembered my tita was also confined about the same time. So what I did is I shifted the attention from me and I started praying, offering up my pain, and my difficulties here during this time of this procedure. I said, and I prayed for my tita that she get better naman. And that act of stopping thinking of myself, it helps because it's not just you. There are other people out there in pain. And you can help them even though you are in pain also. Because God hears your prayers and He will answer them. For sure, He will help you. Because, well, it just so happens that it's Lent, so Christ, He suffered so much pain so that He can help us enter heaven. Which goes to my next story in this line. So I was already in the ICU afterwards. I was alone there, much visitors. But I noticed, technician, lab tech came in to draw blood. Now she couldn't draw it from the usual places kasi my right arm, dun yung access ng stent procedure. So not there. My left arm, meron siyang IV. She had to take it intravenous, baka diluted na yun. So she asked me, pwede ba dito na lang sa may paa? Sabi ko, okay, that's fine. But in the moment of her mentioning that, naisip ko, well, right arm, that's the left arm may IV, tapos sa paa pa. And then I was in Cardinal, so each room had a crucifix. Nakita ko si Cristo. Wow, this is a small simulation of what Jesus went through. It was a reminder for me that he suffered all this for you. You will get better, and you're suffering now, but you will get better also. And it made me be humble to be reminded of all these things in the midst of my thinking of myself and my own problems. So it was a good thing, and it was also a time of thankfulness that God sent His angels to help me out during that day. So the angels from my lab technicians, the Dr. Shapno who happened to be there, Dr. King who was there on the way home, nagpadaan lang, Dr. D who was available. Yeah. These are all angels that God sends. He might not be here present, but he makes use of the people around you to help you out. So just call on him. He will not see him in person. Well, that would be different. You already crossed the line for him. But he will send people to help you. Okay, so that was my first MI. Does that mean there's a second? So I guess, but things were all right after that. Now during COVID, last year in 2022, our family decided to travel abroad because there was an event. The nephew of my wife, Saul, was getting married, but he's in North Dakota. Well, I think we've never been there. Let's visit. And since travel was already being allowed and it's possible, so let's try. So the wedding itself was okay, and everything we visited and billeted in a hotel like that. But unfortunately, I contracted COVID while I was there because the people there were not high on masking or everything. You could see the difference traveling from Asia then going to the States. In Asia, everyone has masks. But by the time you get to the States, wala na nang mask. So you tend to be lax yourself about wearing a mask, which is not a good thing. But pinagsabihan pa kami ng kabataan doon na lalakad lang kami sa sidewalk na may mask. Sinabihan kami na there's no more COVID, stupid. May dalang pang stupid. So that's the culture that was happening. In short, in part of our travels, I was informed by my brother-in-law that he got COVID, so we should test ourselves since we were traveling with him, and we did. And so I did the antigen test, the home antigen test, and it was positive. One of the nice things about this time, COVID in 2022 versus 2020, was now we have these home antigen tests, and then we have more knowledge on what to do, quarantine, we all know that, no masking, we have more information. So once I got the positive test, in the house I was staying with my other brother-in-law in California, they set up a room where I could stay by myself and sort of quarantine myself. Now in the States, at the time they had this program for Paxlovid, the antiviral, and it will be free for anyone who tested positive. You don't have to be American, but you tested positive there, you can get it for free. So why not? So I availed of it, went to the clinic, got tested there, and then got the Paxlovid. The problem was, one of the things is you have to stop taking blood thinners dahil merong interaction with it. I checked with Dr. D first and said, okay, might be okay to do that. For 5 days, I have to take the Paxlovid. So I halted the blood thinners first. However, 4 days later, while on the Paxlovid, I got this substernal burning feeling again, but this time it's very mild. It's like 1 out of 10. It's barely sensed it. But again, it was persistent. It was the persistence that was bothering me. So it wouldn't go, it's always there. It's not a 1, but it's always there. This is similar to what happened before in the persistence part of it. So I decided I better have this checked out. And so they went to the ER. My sister-in-law brought it there. They were our hosts. So, ER, and then the blood test, the enzymes are done. I was told they were elevated. So ECG, I didn't know what the results of that was, but they informed me that I'll have to undergo an angiogram. So, okay, I was suspecting this might have to be done. The difference now between the first time and the second is that the angiogram was finally done 6 to 7 hours later, because of the fact that I was COVID positive. And it's part of, you do the COVID patients last in the laboratory. I knew that would probably be the case. So this is another difference from before. Whereas ang bilis-bilis dati, ngayon, because of the COVID, I have to wait 6 to 7 hours. And this time I was sedated. They didn't ask me if I wanted to be sedated or not. Pero when I was in the cath lab, they injected something. I fell asleep. The next thing when I opened my eyes was I was being told already that it was where the stent was, that was closed, and they couldn't get beyond it. And so the doctor recommended medical management. Okay. Well, parts of me were relieved na no further intervention, meaning no operation required, and then medical management. Of course, I was concerned, how come it didn't open? How come it closed or like that? But since all of this was happening in the time of COVID, they might be all interrelated. And it's sad. By the way, I was fully vaccinated with 2 boosters. It could have been worse, siguro, if I didn't have that. And one night thing, you can see the difference between Pinoy staff, because there were Filipino staff in that hospital. And you can compare it with yung mga puti, mga Caucasian staff. The Caucasians, they were efficient, efficient, a little cheerful. But yung pag Pinoy yung kasama mo, siyempre mas may karinyo, tsaka pwede ka mag-Tagalog, and that's a big relief sometimes to just talk about your condition in Tagalog, which is good. So the pharmacist was Filipino, and then in the ICU, there was one shift nurse na male, Filipino din. And finally, the hospital, what's this? I call this? The intensivist. Well, the house doctor, I forgot the term of the hospital doctor, was also Filipino. And that really, well, put me at ease of being in that environment. So okay. And so we went home. Eventually, I stayed on because to make sure in extended quarantine period that I don't get COVID and nothing happened. And we were wondering, do we have to follow up before we leave? Well, yes, they gave us an appointment, but the follow-up was with it wasn't the same doctors who managed me, but their primary care providers. And this one wasn't even a doctor, it was a nurse who was trained in primary care. So we were thinking, di kailangan ikwento lahat ng nangyari ulit sa akin. Bakit hindi dun din sa doctor na nag-manage sa amin ng follow-up? Pero hindi nun. We just consulted Dr. D. And since things were stable, he said, no, you can come home now. Then that's the time we proceeded to come back here. And then when I got back here, he recommended, why don't we do a cardiac MR to make sure what happened? And so, sige, I agreed to that, to do that. Let's see how it is now. And a cardiac MR is a very good imaging tool to do that. And so the results of that here was that the infarct was completed now. So there was no revascularization procedure would help anymore. So parang naging scar tissue na yung infarcted tissue. So okay, in a sense, that's good. In the other sense, so that part of the heart doesn't work well anymore. By the way, I had experience dun sa loob ng MRI. Kasi having requested those procedures and read some of them, I hadn't underwent one consciously. I had to qualify that because in December of the previous year, I had transient global amnesia. They put me in an MRI, but since it was amnesia, I didn't remember it. But this time, I was awake. Tapos, it's a tube you go into. I can appreciate now why patients are claustrophobic when they can become claustrophobic because the tube is right in front of your face. And tapos, doon ko na realize na it's hard to hold your breath when your lungs are empty. Bakit empty? Kasi the instructions we give them to hold their breath while they're taking the images is hinga malalim, labas ang hangin, pigil ang paghinga. The reason why is that series is para the anatomic position of the structures remain the same. It's the most consistent way to do it. But if you have to hold your breath after putting the air out of your lungs, it's very hard. I could only do, 20 seconds at the most, I'm starting to shake. Buti na lang, most of the series can be done in that period of time. So it was an eye-opener, and I just look at it as payback for all the patients we sent to do that exam. Now it's my turn to do that. So throughout all this, at least I'm home, I'm with friends, my relatives are here, and my doctors are here also. And I'm still here, no? So I'm still okay. I'm talking to you, and I feel happy for that. So right now, I get winded when I go 2 floors upstairs. It takes time for my heart rate to slow down, but our long walks on flat ground and gentle slopes are fine. I can keep going as long as it's horizontal. I don't get tired doing that. So that's my exercise now, 30 to 40 minutes of walking a day, and like that. Then of course people learn about this and they tell me to take it easy, slow down. Okay, I hear that, but I was thinking maybe I was taking it too slow before, meaning not enough exercise, too relaxed, maybe too much eating also. No? But now I just have to make do with what I have. Of course, exercise is important, and I watch what I eat, at least by quantity. If I can't figure out this 52100, but thank you, Dr. Jan. That's a very useful guide, 52100. Everyone should try that. So if there's no need to run, I won't. If I can walk to it, I'll go there, but it might take some time. But still the same, I'll get there. And now I can appreciate the things and the people around me better, since I go at a pace where I can linger longer. And was my experience. And thank you for listening.
Oh gosh, thank you so much, Dennis, for that heartfelt and very sincere narration of what happened to you, your appreciation of the role of God in your journey, the spiritual dimension of it, and how you're still so hopeful, after going through this very difficult process. And so I thought that was a really good balance to John's presentation, to see what the patient goes through. And we'll talk a little bit more about that, but thank you so very, very much for sharing. I know that's not easy to remember all of those things, and there must be some trauma linked to it when you tell that story, but I thought it was really such a sincere and heartfelt sharing for our audience. So maraming salamat, Dennis. Okay, we are going to have an open forum, but before that, Raymond's going to walk us through a public service announcement.
Thank you, Dr. Dennis. Maraming salamat po. We hope that's something that a lot of you, our audience po, was able to relate to, especially those who may not necessarily be getting those lifestyle changes, but hopefully that was something that we learned from the testimony from Dr. Dennis. In the meantime, the COVID communication PSA po, while they are switching on their video cameras, will be part of this very quick break for today. Happy birthday to you.
Maaari na bang magpabakuna ang mga batang 5 hanggang 11 taong gulang?
Oo, nagsimula ito noong Pebrero.
Nagpabakuna na ba kayo?
Oo, nagpabakuna na kami.
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Okay, thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many outputs of the Stop COVID Deaths team to push for pediatric vaccination for children age 5 and above. Please share this clip with all of your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Dr. Susie, maybe we can start off with the first set of questions.
Yeah, let's have John and Dennis open their videos.
Yeah, they're here.
Okay. And we'll take some questions from the audience, but let me sort of get the ball rolling. I remember, John, I was about maybe 10 years old or so when I heard that Paquito Tanco was PGH director, but also a cardiologist, had a heart attack, had a heart attack. The conference of cardiologists in Baguio. Am I correct? Tama ba yun, no?
Yes.
So, yeah. So I remember that very well because all the cardiologists were there at that event. I can't even remember what the event was, but he's my uncle kasi, no? Parang my mom and the wife of Ambrosio Tanco were sisters. So I heard that story, heard about the whole thing, and so I wanted to and after Dennis's talk, I wanted to ask that we talk about how do you keep the hearts of health workers healthy? Kasi yung 52100, no, we know what the life is like in the hospital. You're eating on the run, you'll eat whatever is there. Pag merong may birthday, may pansit, may lechon, may ganyan, no? Tapos, the salt content of the food that people are eating. So, and then you look at the what do you call it? Exercise. Well, of course, moving around, no? But that's a little bit different from physical activity that's more leisurely or good for you. So, I wanted to ask you, John, because most of the people who are watching here are doctors or nurses or physical therapists or our allied medical professionals who are really running a lifestyle that puts them at high risk for a cardiac event, no? So the question I have is this, right? Aside from the preventive measures, how do we what kind of checkup or what kind of monitoring should health workers go through? Yung kay Dennis, biglang sumakit na yung dibdib niya, di ba? Parang, we don't want to get to that point. You said that. So, is there something that the health workers, particularly the doctors and the nurses, can do so that they are aware of a possible risk?
Yeah. Susie, I hope hindi magagalit sa akin yung mga co-doctors natin when I say this.
Okay lang yan. Okay lang yan.
Most difficult patients sometimes are us, really. And I've seen this. I've taken care of some of our friends, and most of us really don't want to go into the rigors of doing regular checkups, having our blood tests done. There's this perception that hindi tayo Superman, no? We have this idea that we will not get sick because we are doctors, when in fact, probably as you mentioned, because of the stresses of our daily work, we're at risk to develop acute coronary events like anybody else. So yung tanong mo is special test, I think we just have to do what the guidelines and recommendation just for anybody else. There's really no special test for us just because we are doctors. What we have to go through would be the same guidelines and recommendations of what we prescribe to our patients. Kasi sometimes nagkakaroon tayo ng yung tinatawag na feeling natin hindi tayo magkakasakit, and we refuse sometimes doing the guidelines, the recommendations that we specifically tell our patients. So whatever you recommend or you advise your patients, do it yourself.
Ayun, so yung 52100 mo, kailangan lahat na tayo dyan, di ba?
Oh, remember, there are some doctors who smoke, no? I hope, again, nobody,
and drink a lot. No?
And ako nga, nakita ko yung 2 hours screen time, parang my God, napakahirap ata, no? With all the, all this Instagram, Facebook, whatever, Twitter that we have. But those numbers are really proven to help us reduce cardiovascular events. And I hope we put that, no? It's easy to remember. Just put in your mind 52100.
Oo. So thank you, John. Thank you. So, Raymond, Dennis wants to say
Comment
something.
from Dr. Dennis.
Sige. Oo, sige, go ahead.
I'm probably part of that group that doesn't do checkups very well, but I did do it not as often as needed. And actually, I already underwent treadmill stress tests 2 or years prior, 2 years, but it wasn't detected. There's no clue. And we know that it's not that sensitive naman. At least if there's something that happens, it could happen. And yeah, I'm part of that group, but I know what to do, but I don't do it when it happens. But it's good to be reminded in seminars like this what to do. So it will inspire us to follow that we do that. So
Yeah.
I also find it hard.
Yeah, thank you for that, Dennis. Mahirap mahirap talaga siya, no? Sige, Raymond, may mga questions tayo. Let's pick it up from the audience.
Okay, thank you, Dr. Susie. I'm just trying to choose one here. Well, this one from Dr. Romy Quintos po from PGH. Great to see new innovations in PGH for our heart patients. Are there also new innovations in place or in the pipeline for vascular patients as well? Thank you, Dr. John, for your inspiring talk.
Thank you, Dr. Quintos. No, so I've talked to you about innovations in cath lab, especially for coronary artery disease, for valvular disease, that's the 3D echo, and then the EP is for arrhythmia. So, ang question is for vascular, no, which is one of the sections of the Division of Cardiovascular Medicine. We actually have probably one innovation that is only limited availability in the big hospitals. This is what we call segmental pressure recordings. You can get pressure recordings in the different parts of the arteries. Now, this is what you call segmental pressure recordings, which again can help you decide. This is very important for patients with diabetic foot. We can make decisions on whether a below knee amputation or above knee amputation or a toe disarticulation is needed by doing pressure recording segmentally. We had that machine already, but it was out of order for a certain number of months. But I just heard, I saw the question of Dr. Quintos in the chat box, and I just called our vascular section. It will be available soon. So that's a device that is not available even in the big institutions. Segmental pressure recordings.
Oh, wonderful. Okay, there's some more questions, Raymond. I saw some
One
in
more
the chat.
question from Dr. Joseph Tortona. Is ASA 80 milligrams once a day still a viable prevention of thrombosis if not allergic to ASA and no history of PUD?
Napakagandang tanong yan. So parang ang tanong dyan, Susie and Raymond, primary prevention.
Yes, sir.
Sabihin, kasi pag secondary prevention, let's just define the term. Secondary prevention, parang si Dennis, nagkaroon na siya ng event, di ba? Ano ba yung mga events na kailangan ka mag-aspirin? A stroke, ischemic stroke, hindi bleed, ischemic stroke or a heart attack, or if you have angioplasty or stent, even in the absence of a heart attack, kailangan mo ng antiplatelet. Yun yung primary, yun yung secondary prevention. Ang tanong ng ating attendee, what if I have not developed any of those and I would like to take aspirin for primary prevention para hindi ako magkaroon nun? Unfortunately, all the randomized controlled trials that were done, madami to, 3 big randomized controlled trials, did not really give us a very robust level of statistical significance that would favor primary prevention of giving aspirin to this group of patients. Okay, but the caveat is patients with diabetes tend to slightly favorable yung magbigay ka ng aspirin to prevent cardiovascular events. So if there's siguro a certain group of patients that might benefit, might be the diabetic patients. But otherwise, yung primary prevention, at least if you're evidence-based medicine, wala pang robust evidence that it is useful.
Yeah, thank you very much, John. There's one more question in the Q&A, Raymond.
Yes po. This one is I think it's mostly about the management din po at the prevention. Her sister is a polio patient. Yeah, she's asking how can the sister manage her hypertension better if there is very limited movement, so no exercise na daw po, and she is now 57 years old, Dr. John.
Yeah, okay. So ang tanong dito ay what can we do for a patient who has very limited mobility, no? Polio patient. I think there's still even in patients with polio, we can still do some activities that will generate movement, no? The best rehab, even you can, sorry po, kung may Google kayo, you can even do this, no? What activities can be done for those particular patients. Now, if you are unable to maximize the exercise for your patient because of the limitations imposed by her illness, then let's na lang maximize the other lifestyle modifications that we can offer to your sister, no? Yung diet niya, enough sleep, even adequate sleep is very important, no? We should not we should put that also in the equation. Hindi ko nasabi yun dun sa 521C0, but studies really have documented at least Susi, 7 to 8 hours.
Oo, kaya 521-007 na tayo.
Oo, dapat isama rin natin yun, yung adequate number of hours sleep. So, marami pa pong interventions other than exercises because of the limitations imposed by the illness of your sister that we can help in bringing down the blood pressure. But you have to realize medication is a big factor, especially if the blood pressure is high. It cannot be controlled by your lifestyle intervention. Then you have to make sure that medications is religiously and adherence to taking the medications is done.
Okay, thank you so much, John, for answering that. You know, we would like to go on and on, but we are running out of time. And so we're going to answer the fun quiz. Raymond's going to walk through the questions so that our audience will know if they got the answers correctly.
Thank you so much, Dr. Susie. Can we also have on the Slido yung ano po natin? The question. Okay, there we go. So for the two questions, we'll ask Dr. John to give the correct answer. I'll read the question and then he will give the correct answer. For the first question, ano ang mga palatandaan na ang isang tao ay may posibilidad na may heart attack? Dr. John.
Okay, so first of all, thank you. Ang dami nating attendees, Susie and Raymond. 311 responded, no?
Yes po.
So ang nakita ko dito, 91% said lahat ng nabanggit or all of the above.
In the Zoom, sir. Yes, sir. Opo.
Yeah, in the Zoom. Yeah, tama po lahat ito, no? Yung lahat ng symptoms or simptomas ay pwede pong mangyari sa isang pasyente na may heart attack. Pananakit ng dibdib, hirap sa paghinga, and even numbness or pamamanhid ng kaliwang bahagi ng katawan. You don't have to have all of these 3 present. Sometimes baka 1 out of the 3 lang or 2 out of the 3. But any of the 3 possible symptoms can present as an acute myocardial infarction or heart attack. So ang tamang sagot, lahat po.
Okay. Thank you so much. For question number 2 reads, what are the therapeutic options for a patient experiencing an acute heart attack, Dr. John?
Okay, napaka-importante ring question na to. Sa mga nanonood sa atin ngayon, for all our attendees, remember, the dictum is, please, if you think you're having an abnormal symptom, like si Dennis nga, nakwento niya, no? Everybody, we have that perception na yung epigastric pain can be gastritis or peptic ulcer disease. But if it's something abnormal to you, first time mong naramdaman, especially kung may konting chest heaviness, yung chest tightness, medyo namamawis ka ng konti, basta you feel uncomfortable. Yun ang sabi nila eh. May feeling ka ng uncomfortable, you have to go to the hospital. Kung hindi ka sigurado, ang tandaan nyo na lang dito, kung hindi ka sigurado, it's okay. Pumunta ka sa hospital. Kung sabihin nilang hindi heart attack, fine. But you have to make sure you have at least an ECG. If it is really an acute heart attack, the ECG will give us a very good diagnostic test. It's a very good diagnostic test. Now, when you have an heart attack, for example, nasabi na ng doktor, meron po kayong heart attack, what can be done? Thrombolytic therapy is giving blood thinners intravenously, no? Angioplasty and intracoronary stenting, yan po ang diniscuss ko kanina. That's what you call percutaneous coronary intervention. And yung pangatlo, medical management. You give aspirin, you give clopidogrel, and other drugs. So if you look at this, any of these are therapeutic options for a patient with heart attack. Ang difference na lang po, sa Metro Manila at sa mga malalaking siyudad na merong kapasidad, if you are in an area where there is capacity or capability to do percutaneous interventions, that's angioplasty and intracoronary stenting, based on studies, especially if the artery involved is the left anterior descending artery, or you have an anterior myocardial infarction, studies have documented more benefits with PCI or intervention compared to thrombolytic therapy. But if you are in a setup where intervention, remember you were talking about the 120 minutes, no? Importante yon. Where there is no facility for cath lab, there's no way you can have an intervention. Or medyo malayo, it will take you more than 6 hours bago ka makarating dun sa next hospital, ay nag-heart attack ka na. Thrombolytic therapy is a very good option. Okay? In those both, ang tawag dyan, revascularization procedures. Both of them are revascularization procedure. One is medical, thrombolytic therapy. The other one is interventional, the angioplasty and stenting. But both of them will require medical management after you've done the revascularization procedure. So the answer here would be all of the above.
Okay, thank you so much,
Okay.
Dr. John.
Galing talaga paliwanag ni John. Talagang kala ko madali lang yung sagot dun eh. Pero ang ganda ng paliwanag niya, no? I mean, thank you so much, John. We really, and you can see that the audience appreciates your lecture, your inputs, and even just answering these questions. Okay, so we are going to give both Dennis and John a minute or two to just formulate your closing remarks for our audience, like what are your last words for them. Meanwhile, Raymond's going to run a evaluation. Go ahead, Raymond.
Thank you, Dr. Susie. So for our evaluation poll, if we can have it on the screen right now, it's just 5 questions po, no? 4-point Likert scale. Really I'd like to take this opportunity to thank Dr. Dennis Bautista from the Hospital Muntinlupa for that excellent testimony, and then for the excellent lecture from Dr. John Anonuevo, who is the chair of the PGH Department of Internal Medicine. The 5 questions are as follows. The panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing our evaluation poll. Wala rin po tayong hiwalay na isi-send out. We will ask na po now our speakers to give their 1 minute or so na final message to our audience. Dr. Susie.
Okay, thanks. Let's start with Dennis. Dennis, what are your parting words?
Okay. Parting words. Well, 1, pray. Number 2, follow everything Dr. John said, especially the last few slides. They're simple, easy to understand, and if you do it, you won't have to go through what I went through.
Thank you so much, Dennis. This is Dr. Dennis Bautista. Okay, let's go to John. John, anong parting words mo?
Okay, so tandaan niyo po, merong spectrum ng cardiovascular disease. There's an spectrum. Merong beginning at may ending. Ang ending po ay death. Huwag nating paabutin. Doon tayo sa ending. Ang ibig sabihin pa lang noon, sa simula pa lang ng spectrum, the beginning, take a good action already. When you say beginning, you take care of the risk factors. Diyan po, tatakbo yung 52100. Sa simula pa lang, when you're young, where you still don't have the diseases that can cause death, take good care of yourself. Involve the 52100, and I'm sure you will not go to the ending. Now, in the event na nandun na kayo, wala na tayong magagawa, you've missed your chance not to have all those problems. There are a lot of innovations that are available. You can have this even po. I-announce ko na to sa mga pasyente nating walang masyadong kapasidad na magbayad. Kami po sa PGH ay nandito para matugunan ang karamihan ng inyong mga problema sa puso. We actually have almost all the available innovations that you can find in a big institution. It is available here in the Philippine General Hospital, and we will be glad to serve you. Thank you, Susie. And
thank you so much, John, and thank you for your time, for preparing and all. Raymond, you want to share the results of the evaluation?
It's still ongoing, Dr. Susie, but 58% have 59% have now responded, with at least 94% of them indicating na talagang well-received at marami po silang natutunan for this presentation. So maraming salamat po ulit kay Dr. Dennis Bautista and to Dr. John Anunueva.
Yeah,
Go ahead,
you.
Dr. Susie.
We had such good speakers today. And for our closing, none other than Stella Marie Jose, who is the head of the PGH Expanded Education and Training Program. Stella, take it away.
Go ahead, Dr. Stella.
Yeah. Good afternoon, everyone. We have a very high yield lecture from Dr. John Anunuevo, and also a very touching testimony from Dr. Dennis Bautista. Dr. John Anunuevo mentioned at the start of his talk about the presence of 3 catheterization labs here in PGH. And he mentioned that coronary angiography is the gold standard test to appropriately diagnose and manage patients with coronary artery disease. He also mentioned the inherent limitation of coronary angiography is because it cannot fully characterize the significance of the coronary artery stenosis. So he mentioned that here in PGH, we have the pathway that was created by the Department of Internal Medicine, the UP-PGH STEMI, which stands for ST wave elevation myocardial infarction. So there is that 120 minutes of time that the patient is brought to the cath lab and undergo primary percutaneous coronary intervention, and that saves the patient's lives. In 2021, we had 120 cases of these patients. He also mentioned the other modalities that we have here in the PGH, the intravascular ultrasound, the optimal coherence tomography, or the OCT, which is 10 times better resolution, and it will teach you what is the best procedure for the patient. He mentioned about fractional flow reserve, which is the gold standard for assessment of physiology, severity of the lesion, and the FFR value of less than 0.8 shows a critical situation for the patient, and a value greater than 0.8 means that intervention is not necessary. He mentioned also about radiofrequency catheter ablation. And at the end of his talk, he mentioned the numbers 52100. 5 meaning 5 servings of vegetables. You limit your screen time to 2 hours, 1 hour of exercise every day, 0 cigarette smoking, and 0 colored drinks. Okay, so all sodas, soft drinks, and juices, we should minimize those. Now, our next speaker was Dr. Dennis Bautista, a radiologist, and his talk was really heartwarming. And you see that the event, the cardiovascular event that happened to him, the first time he was very lucky because the time interval was very short and he underwent stenting at once. But however, when COVID came along, we know that it makes the blood hypercoagulable, and for his second encounter with the myocardial infarction, it turned out that he has to undergo medical management alone. Okay, so all these are learning points for all of us, and we salute really Dr. Dennis Bautista for his honest testimony and his heartfelt testimony. I really congratulate both our speakers for a very, very good presentation. Thank you. Back to you, Susie.
Thank you so much, Stella, for that very concise summary. And again, thank you to our speakers. So next week, don't miss it. Ang topic po natin ay poison, lason. We will have the National Poison Control Center of the Philippine General Hospital, NIH, with us. And we will talk about poison. I'm sure this is something that you're all very interested in. So next week, abangan nyo, join us for this very exciting discussion. Raymond, over to you.
Thank you, Dr. Susie, and thank you also to Dr. Stella Jose, really for that brief but very malaman po na synthesis and closing remarks. Before we conclude our program, All Stop COVID Deaths webinars po, no? Not just itong araw na to, but all 137, maging 138 na po will be and can be found in the TVUP YouTube channel. So you just go to youtube.com/TVUPPH for you to be able to see all of those, including ito pong SCD shorts po natin na selected presentations, very, very consumable po, no? Whether you're waiting for someone in the restaurant or you're commuting, etc. And baka napapatulog lang po kayo. These are really very helpful and valuable, hopefully, at that you'll be able to gain nuggets of wisdom from all of these. So this formally closes our webinar for the week. Magkita-kita po tayo again next week from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.